talking about how incentive payments are based on outcomes after the close of a 12-month performance period. And one thing you need to understand about this is each episode of care is not settled individually. This is based on averages. So generally there will be a 12-month performance period which all of the includable episodes will be tracked and averaged, and at the end of the year that average cost again will be compared to pre-established targets to determine whether there is efficiency created and savings to be shared, or if it's a break-even situation, or if the costs are higher than what's considered acceptable, and then there's a shared risk arrangement in that. But again, it's a situation, and you'll see this in a little bit, that these targets are predetermined, so it's actually possible that every single principal accountable provider in this initiative could actually share savings. You might ask, why would an insurance company want to do that? And if any of you understand some of the concepts of the Accountable Care Act, or PPACA, as some people talk about it, there's a provision in there that basically says that there's a minimum medical loss ratio for insurers. So in other words, if an insurer doesn't pay more than 85 cents on the dollar of premium for a large group, then anything under that has to be returned to premium paying customers. So in the past, as insurance companies have made underwriting gains and put those in the bank for years where they don't make underwriting gains, that's not possible anymore. So what the payers are thinking is there a way for us to use those dollars maybe more effectively and constructively by using them for incentive purposes to reward good work in the system in creating efficiencies, as opposed to just paying those dollars back to premium paying customers? Now, don't get me wrong, I think they would appreciate those being paid back, but probably wouldn't really understand why they got it back, and it for sure wouldn't change any behaviors as far as those customers are concerned. We think that using some of those monies to incentivize providers for the good work they do may be a wiser use of those dollars. Now, for the premium paying customer, this also means that if we're effective, we can keep premium costs at a level that is not going to get higher than they can afford to pay, and we see more uninsured in the system. So we look at this as a methodology that offers a lot more opportunity than it does threat, and we appreciate you being here to learn a little bit more about it. So, Bill?
Sure. Let me go to the next slide. And, we've been constructing these episodes using clinical literature, practice guidelines, local expert commentary, commentaries from work groups like this. And we're trying to design something that makes sense and makes clinical sense and is fair to patients and providers. I think we've succeeded in doing this. Now, to give you a sense also, what this program actually results in doing is that most physicians, most providers, if it's a hospital, in this framework either ends up being revenue neutral or actually in a gain-sharing mode. So in many ways, rather than, as Steve was saying, that we're facing things like benefit limitations or reimbursement cuts, this proposal actually is probably one of the more positive angles for providers that we can come up with. And I can tell you that Medicare is very interested in this, and the rest of the country, and even internationally, some of the consulting activities that McKinsey does, everybody everywhere in the world is now facing, how do we provide effective services to our populations given the revenues and the dollars we have, or the euros or whatever, to provide those services. And so the framework, to give you a sense of what's happened, is we now have a collection of data each episode for the average cost of the episode by the principal accountable, attributed to the principal accountable provider. So if it was a delivery, it was all of the care delivered for the pregnancy for patients by an obstetrician who at least took care of the patient for at least 8 weeks of the pregnancy. If it's a cold, it's all the services provided by the first person to see the patient for the cold in that like about 30-day window. So whether they got x-rays, antibiotics, went to the ER, sometimes it's the ER is the first person who saw the patient. And what you have is there's biologic variation, there's style variation depending on the patients. We have some exclusions, so patients who have like cystic fibrosis or sickle cell are not in the average cost per case. So you may have each of these bars represents a single provider and their average cost for providing care, total care for that episode. And most of the providers we have in this have to see at least 5 patients over the course of a year. So this is over a year's period of time. And we crunch a lot of data. And we end up with curves. Very often they'll look like this. We have low cost per episode, and we have high costs per episode per provider. And what we have done is we have what we call different lines of set. So we have thresholds, and we call this line here the acceptable threshold. And anything above, any folks who are above this acceptable line, they actually are at risk for 50% of their average cost above the acceptable line. And I'll show you a slide in a minute. If you're below the acceptable line, which is 80% plus, and you're between the acceptable and the commendable, you've gotten your fee for service, and you get no bonus, you have no risk, you've done your care for the year, and that's the end of the story. Then there are folks who have below the commendable line. These are folks who have provided services, have met quality metrics, and therefore they are coming in more effective in their care than their peers. And these folks are actually now gain sharing 50% on their average case between the limit and the commendable level. So they are actually getting more per case than they got from just the fee for service. And then finally, there's this gain sharing limit. We've designed these things where there reaches a point where we're not sure why or how somebody could get below this level. So there's not an unlimited gain sharing. At some point, we say, perhaps there's a floor where you start wondering about the quality of what's being given. So we have put in a floor so that below this, if someone did get below that, I'm not sure anybody has, that we don't do further gain sharing. Let's talk about the commendable. So let's say that you as a provider or gastroenterologist, your average colonoscopy was $200 on average below the commendable line. Or if you're a surgeon, or pick a number, pick a procedure, and you're $200 below the commendable, you would get back 50% or $100 per case. So you'd be a 50% gain share. Likewise, at the other end, if you were above the acceptable line, you would be at risk for 50% of your excess up to 10% of your total reimbursement from that payer. Now, the only thing to keep in mind is these numbers are based on total cost of care and not just your fee. So there is a little bit more dollars here involved than just your fee.